Hi guys, this is Mrs. Zegler. We are going over skin integrity and wound care today. As you can probably already tell, this is a very lengthy chapter, chapter 32. We are going to go over 78 slides with voiceover. It is very lengthy. I will recommend that you take lots of notes as you listen to this voiceover PowerPoint. And I will tell you, as we go through the slides, there are some pretty up close pictures of different types of wounds. If you have a weak stomach, they may make you a little bit queasy, so just be aware. But it is important, it kind of drives home the point that we're trying to make with each slide, so we do want you to be aware that there are some graphic pictures as we go along. Thanks. This chapter starts out with the anatomy or the structures of the skin. Our skin is our largest organ. It has many functions and is essential for maintaining our life. When we think about the structures, it starts out with the epidermis. This is that protective waterproof layer. We do not have blood vessels, or there's no blood vessels, so it relies on the underlying tissues for nourishment to this area. The second layer that we have is our dermis. This is that elastic connective tissue. It has our nerves, our hair follicles, our glands, our blood vessels. And then we have the subcutaneous tissue or layer. And this anchors the skin to our body or tissue. It stores fat for energy, serves as a heat insulation or insulator for us. And it has blood and lymph vessels and nerves as well. As I said, our skin has many functions that are essential for us maintaining life. The first function of our skin is protection. It acts as that first line of defense or that barrier. It protects us against infectious agents. It decreased injury to underlying tissue, and it prevents our loss of moisture. The next function that it has is our temperature regulation. It's responsible for evaporation of perspiration. It draws heat draw from skin. We also have psychosocial function, which is just that external appearance. It's a major contributor of to our self-esteem. It plays an important role in communication and identification. Function. Our skin also functions in regards to sensation. It senses touch, pain, pressure, temperature, and allows our body to adjust to environments related to that. Our skin's responsible for our vitamin D production. So it's a precursor for vitamin D in the skin, and ultraviolet sun rays produce that vitamin D. It has immunologic purposes, which if we a breach in skin or if we have some type of cut, it triggers the skin immune response to protect us. It's responsible for absorption. Substances can be absorbed through the skin for local or systemic effect. We have many medication patches out there that we give medications because we know the skin can absorb it through a patch type method. And then elimination. So water, electrolytes, and different waste is excreted through our sweat. So it does have many, many functions. I highly recommend, as you're taking notes here, that you kind of star this information and then you are aware of the different functions that skin has. When we think about skin as an organ, part of the skin that needs to be included that is also our mucous membranes. And that lines our body cavities. It protects the body from foreign material, secretions of mucus to moisten and lubricate, and is also known for absorption. So when you think of, the structure of the skin, what the skin organ includes, you also need to remember that it includes mucous membranes. So the book discusses basic principles to our skin integrity. It's important to note that unbroken and healthy skin and mucous membranes serve as our first line of defense against harmful agents. Resistance to injury varies among people. There's different factors that can influence that, such as age, underlying illness, different things like that that we're going to get into. But it does vary. Adequately nourished and hydrated body cells are more resistant to injury. And then adequate circulation is also necessary to maintain cell life. If we don't have that adequate circulation, um, our skin becomes impaired. So, all of these are just basic principles when we think about factors that are going to affect our skin integrity. Continuing on, what are some factors that affect our skin integrity? Your textbook on page 1046 has a great table that lists these factors. The first one, and the one we're going to talk about a lot today, is age. As we begin to age, our skin becomes thinner, um, is more prone to tears or injury. So, that is a huge factor that's going to affect our skin integrity. Your textbook goes on to talk about lifestyle variables. Body piercing. I mean, that's a lifestyle choice. And we'll talk a little bit about what's considered a wound, and it's basically any break in the skin. Well, body piercing is a type of break. So that is a factor that may play, or example of a lifestyle variable that may have an impact or factor on somebody's skin integrity. Different occupations, as far as those that are outside, exposed to maybe sun all day, maybe they're into construction. Um, Again, that's a lifestyle variable that can affect their skin integrity. Um, your book also goes into talk about in this table lifestyle variables. It talks about homosexuality, a history of multiple sex partners, IV drug use, and things like that. And as far as the homosexuality, the nursing implication it gives for why that's a factor of skin integrity, it states these patients are at high risk for infection with HIV and AIDS, so that makes them kind of at risk. Um, and so, the same with IV drug use, them using possibly a contaminated needle would affect their skin integrity, place them at increased risk for infections, so things like that. Nutrition is another one that affects our skin. And when we think about that, you have to think about a patient that's maybe dehydrated or malnourished is going to impact that. Illnesses, we have patients that are ill. They may have some neuropathy in their feet, which is a decreased sensation. They may have some conditions that decrease circulation, and those patients are at increased risk for their skin breaking down. The level of activity or therapeutic measures, I put that on here. It is in your box. So if you have a patient that cannot get up, cannot move, does not have a high level of activity, those patients, may end up being bedridden. And those patients are at risk for having skin breakdown if they lay in place too long. So a patient with a cast could have some potential increased skin breakdown. Certain medications may make their skin weak and cause that. So those type of therapeutic measures or their level of activity do impact our skin integrity. And then your book has another one, diagnostic measures. As we get into the lecture about bowel and elimination, if a patient's going for a GI study, a lot of times they have to clean kind of everything out that can cause an increase in diarrhea for a patient. And with that, they could possibly have some skin breakdown. So your book does list that as a factor that places a person at risk for skin alterations. Again, this table is a great one to kind of highlight, look at. As far as nursing implications, it is in your book on page 1046 and it is table 32-2. As we continue on about factors affecting skin integrity, it is important to note developmental considerations when we think about the young and the old. So, an infant under the age of 2, they have thinner, weaker skin that can increase their risk of impaired skin integrity and infections. So that's very important to be aware of. And then our older individuals, as I said, they their skin becomes thinner. They have decreased elasticity. And they can be more susceptible to pressure ulcers and just that disruption in their skin integrity. As I previously stated, I said we would be going over a lot of talking about the elderly population when we talk about skin integrity. This table is in your book. It's on page 1047. And I included it in this PowerPoint just to kind of give you um, a way to identify some age-related changes you may see with an elderly person in their skin, and then nursing strategies that we can implement to assist with that. Um, their skin is more thin, it can be easily injured. Um, they have maybe a less capacity to insulate. Their skin's more wrinkly. And their sensation of pressure and pain is reduced when we talk about the subcutaneous and dermal tissue layers. And so, some things we want to watch for is possibly do we really want to apply tape to their skin in the hospital setting? Sometimes we have to secure something. We need to be thinking about, well, what is the best tape? There's lots of options out there. We don't want something that's really sticky that when we pull off, it would possibly rip their skin. We want to check their skin frequently to observe for signs and symptoms of skin breakdown. Um, and you guys have this table here in this PowerPoint. It's in your book, and you guys can read through this. I'm not going to lecture the whole thing because, like I said, this is a very long PowerPoint. But I just want you to be aware of to look at this, that we want to, when we think about the focus of the older adult, that they do have a lot of age-related changes, and there are nursing strategies out there to prevent them from having skin breakdown. The state of our health impacts, as we said, that is a risk factor for our skin integrity. So, those with very thin skin or a very obese patient can be more susceptible to skin irritation and injury. Fluid loss. When we are sick, we're having fever, vomiting, diarrhea, any reduction in fluid volume. That if we're having excessive perspiration, that could predispose us to skin breakdown. Patients with jaundice, they may be more likely to scratch, which can cause an open lesion. And then there's diseases of the skin. This is a good picture of some eczema and psoriasis. These can cause lesions, and they may require some special care as well. So our state of our health, as stated, illnesses can impact it, and these type of issues can affect our skin integrity. So a minute ago, I was talking about any disruption in skin, such as body piercing, would be considered a wound, and that is pretty much the definition of what is a wound. It's any interruption in normal skin and tissue integrity. There's a great table in the book. I've listed the page number here, and it talks about the different types of wounds. And the next few slides, we're also going to go over that and show some pictures here. But just be aware, any interruption in normal skin tissue would be considered a type of wound as the definition of what is a wound. So as I said in the previous slide, I said we would talk about the different types of wounds. And again, that's that break in the tissue of our skin. So an incision, as you can imagine, the first thing that comes to mind is like a surgical incision. So we are purposely cutting with a sharp instrument. We're causing that disruption in skin for a surgical purpose. The next one is a contusion. This is when a blunt instrument or may cause it And you have overlying skin that remains intact, but there's injury to the underlying soft tissue. So think of it as possible bruising or a hematoma. So we've kept that top layer intact, but we do have some injury underneath. Abrasion is just that friction rubbing. We scrape our knee or at that epidural skin layer, that top layer. A laceration is tearing of the skin and tissue with a blunt or irregular instrument. The tissue is not aligned, so we don't have that perfect cut like we would with an incision. We may often have some loose flaps of skin still hanging there with the tissue. A puncture is when we have some type of blunt or sharp instrument puncturing the skin. And then a chemical. So there's very toxic agents out there, such as drugs and acids. And if that substance were to get on the tissue, a lot of times it will cause a burn or a disruption in the skin type. And the next slide is just a few pictures to demonstrate these terms that we just mentioned in this slide. And as I said in the previous slide, these are some pictures to give you a visual of an incision. So the top picture on your left-hand side, if you're looking at the screen, is that surgical incision that was made. This one has been stapled shut. The next picture next to it at the top is that contusion or that bruise where the skin's still intact, but we have that underlying tissue damage. Then the middle row here on the left, we have an abrasion as if you fell and skinned your knee. The next one to it is a laceration where we have that irregular cut with some type of object. And then a puncture where something has punctured into our skin. We're continuing on here with types of wounds. Sometimes wounds are caused by something. This gives some examples: thermal, with some type of high or low temperature that caused damage to the skin, and we consider that a wound. Irradiation with ultraviolet light or radiation exposure. Pressure ulcers. So we're going to get into really in depth in this PowerPoint with pressure ulcers. We're going to talk about staging of them. They are a huge problem, especially in our elderly. We worry about that. But basically, they're caused by compromised circulation, secondary to pressure, or some pressure with friction, and they cause this break in the skin. Venous ulcers, when we have injury and poor venous return resulting from underlying conditions such as some type of heart valve incompetency or obstruction, we will see wounds possibly happening. Arterial ulcers are injury and underlying ischemia resulting from underlying conditions such as thrombosis. And again, the next slide will have some pictures for you to visually see that. And then diabetic ulcers, we get that injury and underlying diabetic neuropathy where they lose sensation, but they have some peripheral arterial disease, and it affects their foot structure. So here are some examples. This is a very extreme, this first picture of a buttocks area. It is pretty extreme, but this is how bad pressure ulcers can get to. And we don't want to ever have somebody have a pressure ulcer to this extent, but this is an example of that. The picture below it of the person's foot, that is a diabetic ulcer that can result from patients with diabetes that have that poor circulation and neuropathy in their feet. And then there's a good little informational slide or picture here that has arterial versus venous and kind of talks about the cause and the risk factors and the characteristics, and it gives you some pictures here for you to look at. So when we think about wounds, we have very ways we can classify wounds. Some of these include intentional versus unintentional. We can classify them by open versus closed, acute versus a chronic wound. And when we get into pressure ulcers, we can start to talk about partial thickness versus full thickness versus a very complex wound. So there's multiple ways. In the next few slides, we're going to talk about this. As you can tell, there's a lot of terminology within this chapter as well. So just being aware of what, as we go through these slides, what the definition of an open wound versus a closed wound would be something we would want you to take notes on. So when we think about intentional and unintentional wounds, so this first slide here is about intentional wounds, and that's that perfect incision I was talking about. As a result of a planned intensive therapy or treatment, normally these have shorter healing time and a decrease in risk of infection because we are making this wound with a sterile environment. So if this patient was having a surgical procedure here and we were cutting something out of them, we would make this perfect incision as you see in the picture. We've done it under sterile environments, so we're trying to decrease any risk of infection with that. And then we have these perfect approximated, is what we call them, edges. So the edges go back together almost perfectly. We're able to staple that up, and it will heal much quicker when we get to begin to talk about the healing methods and time. So this is an example of an intentional wound when we're talking about classification. When we think of unintentional wound, that's that accidental cut that happens, and it occurs with unexpected trauma, such as accidents, forcible injury, possibly burns. And these, as you can see, the example of the picture, we don't have that nice, well approximated edge possibly with these. These will take a little longer to heal because they weren't, this cut was made and it probably wasn't with sterile technique. We are at a higher risk of infections with unintentional wounds. And again, the appearance of this, sometimes they're jagged. Sometimes you may have some uncontrollable bleeding, and you have sometimes more tissue loss with these, so that takes a little longer to heal as well. As we continue on with classification, we have open wound. And this, again, is just a different way to classify the wound. So we have open wounds versus closed wounds. So an open wound is, again, that secondary to trauma, that laceration or that cut, whether it was intentional or unintentional. The epidermis is damaged and it's open. We can see underlying structures. You're going to have bleeding. You're going to maybe have some increased risk for infection, especially if it was an unintentional wound. And then a closed wound is that contusion that we were talking about. It's secondary to some type of blunt trauma where our epidermis remains intact, but we still see that underlying tissue damage and that bruising or hematoma. And these are pictures here to represent that. Again, just a different way of classifying a wound. And again, we're still with classifications. We can classify a wound as acute versus chronic. An acute wound heals within days to weeks. We see it follow the expected healing pathway, and we're going to talk about what that expected healing pathway is in some future slides here in this presentation. But again, usually our wound has some edges that are approximated, for example, surgery. The example I'm showing in this picture, it looks like a skinned knee. Not much tissue is gone, just the top layer. And so this will more than likely heal within a few days or a week, and we'll have that normal healing path. But when we begin to talk about chronic healing, or chronic wounds, we begin to see a delay in healing. So something happens, some type of infection, where this gets stuck in the inflammatory stage of healing. And as I said, we'll go through those stages. But we see this a lot with pressure ulcers, venous or arterial ulcers. And so chronic wounds, again, are much worse. They take longer to heal. We have this increased risk of infection with those type of wounds. The picture I'm showing here, as you can see, this patient looks like there's quite a bit of tissue missing, which will cause that delay in healing or longer healing time. We don't have well approximated edges with this. And again, you can see the redness around the wound in this picture. And that kind of signifies that we are stuck in this kind of inflammatory stage where the wound is not getting better. And this last stage of how we might classify a wound is regards to wound thickness. And we will talk a little bit more about this when we talk about staging of pressure ulcers. But we have wounds that have partial thickness, meaning all or a portion of the dermis is intact. We've got full thickness where the entire dermis and the sweat glands and the hair follicles are severed. And then we've got complex, where maybe the dermis and underlying subcutaneous fat tissue is damaged or destroyed. So again, we'll talk a little bit more about these terms right here as we get into staging of pressure ulcers. So to begin wound healing, and again, the next few slides are about the phases of wound healing, but we can talk about wound healing as far as, is it healing with primary intention, secondary intention, or tertiary? And there is a mnemonic in your Lippincott textbook that might help you to visualize and remember this. But when we think about primary intention, again, I talked earlier about that surgical incision that's made, and it has these well approximated edges to the wound, and it closes easily, and it requires very little tissue replacement. And this is going to heal by primary intention. It's not going to take as long to heal. Again, we have that decreased risk of infection if it's done under a sterile technique. And then as we move on to secondary intention, this is when the wound is more open. You have that lacerations. The edges aren't as well approximated. They're more widely separated. There's some type of loss of tissue there. And whenever there's a loss of that tissue, it's going to require more tissue replacement, which makes that healing time longer. You're probably going to have more scar tissue with this type of wound healing. If a wound is healing, oh, this is just a side note. If a wound, say a surgical wound, is healing via primary intention, but suddenly becomes infected, it will now heal via secondary intention. And so again, and it's just kind of categorizing wound healing itself. And then tertiary, the book talks about this, and it's just when we leave a wound intentionally open. And sometimes this is done, or sometimes we delay closure to allow for some edema or infection to resolve, or we need some fluid to drain, and then we're going to close it. And usually these are with types of wounds that have a large amount of tissue replacement needed. And so for these reasons, we will leave it open and then eventually close the wound. And with this type of healing, this is referred to as tertiary. So what are our phases of wound healing? So earlier I mentioned when we have chronic wounds, they get stuck in the inflammation stage. And so there are 4 phases of wound healing. The first one is homeostasis, which the next slide we're going to talk about. We'll go over a little more detail with that. And then the second stage is inflammation. Third is proliferation, and the fourth stage is maturation. And you'll kind of see the picture here. It kind of gives you an example of those states, and those are on future slides as well to refer back to. So the first stage of wound healing is the homeostasis, and this occurs immediately after that initial injury, and it can last for up to 2 days or more. But we'll start to see the vessels constrict, platelets are clustering or clotting to the area that was cut. We have some brief constriction to that area. You'll begin to see some possibly swelling, pain, or increased heat or redness at the site. And this is from when the vessels dilate and the blood components leak into the area, forming an exudate. We may even start to see a little bit of a scab formation happen. and platelets are then stimulated, or platelets then stimulate other cells to come join them in the healing, and beginning the next phase of healing, which will be our inflammation stage. So this is that initial what happens when you cut your finger, for example. This is what occurs. As we go into the second stage, the inflammation, that second picture here on your right, this will follow that initial homeostasis phase. It may last anywhere from 2 to 3 days. Again, if we get stuck in this phase, which you will see with possibly chronic wounds, we've got some problems going on. But this is the primary function, this phase right here, is to stave off infection during the wound healing process. So the white blood cells begin to move to that area. They begin to clean the wound of foreign material, bacteria, and debris. And again, the wound may have some inflammation, some heat, some redness, pain, and swelling to the site, and that's to be expected. And you may kind of see that scab area still in the stage. So now we're at the proliferation stage. This is the third part of our wound healing phases. And this is where we're starting to get new tissue formulation. This can last anywhere from several weeks to years, depending on the size of the wound, depending on how much tissue was lost from that wound. And so it kind of goes through here on the PowerPoint and talks about the process. We begin to produce some collagen, secrete growth factors, induce blood vessel formation. So this takes some time. We start to have some granulation tissue form, and that may be with secondary intention granulation forms to begin covering that cell. And the white blood cells have largely migrated away from the wound now. We're out of that inflammatory stage where they're trying to stave off infection. They've done their job and they're kind of moving away. And the systemic symptoms, like we were talking about earlier with pain and swelling and redness, those have all kind of disappeared in this stage. Our last stage of wound healing is that maturation. And again, this is kind of the remodeling stage, which is what this fourth picture to the right of our words here is trying to show you. So this can begin anywhere from 3 weeks after the injury to possibly continue for months to years. The collagen is now remodeled and new collagen continues to be deposited. We're forming kind of that scar area. Something to note is scars do not sweat, grow hair, or tan. And scars can limit our mobility as well, depending on the size and how big they are. So this is the last stage of our wound healing. I always like to, after I've gone through each stage of the wound healing, I kept this picture in this PowerPoint because it kind of is a better visualization. So you know that of each stage. So this first finger that we're looking at is obviously homeostasis. The injury just happened. The second stage, we start to see that inflammation. We start to see a scab forming. We still have some redness. The third stage, or the third finger here, is the proliferation stage. We're starting to see some tissue formation there. And then our last one is our maturation, where we're having that remodeling going on with the finger. So this is just another visual aid to help you see those stages of wound healing. So we've gone through the wound healing phases, what should occur with wound healing. So what factors affect that wound healing? And we've got a list here. There can be local factors which occur at the wound which prolong that healing. So any pressure, and again, this is a long PowerPoint. We're going to talk about pressure wounds, but when you are laying in a bed, we tend to have pressure to our bony prominence areas, and that can interfere with blood flow to the tissue. So, you know, if we have prolonged pressure to an area, we're not getting the proper blood flow, and that can affect a wound. Dehydration. Again, our skin is best when it's hydrated. So, it tends to die in a dry environment, and that can kind of cause crust to form over the wound and prevent its healing. Overhydration, too much moisture can cause changes in the pH, overgrowth of bacteria, erosion of skin, and infections. So that is another thing we have to watch for. Trauma, so repeated trauma. So, if you fell and skinned your knee and it's in the middle of healing and you fall and skin it again, that trauma is going to delay, obviously, that healing process. Edema, which results in inadequate supply of oxygen and nutrients to the tissue, so that can cause problems with healing. Infection, we're always wanting to be concerned about infections and signs of infection because the energy is diverted to fight the infection and as little is available to repair and heal the wound. Necrosis, which is dead tissue. If we have dead tissue to a wound area, we've got to remove that or we're not going to have proper healing. Excessive bleeding that has large clots, increase the space that must be filled with the during the healing phases, and it can interfere with our O2 diffusion. And then a biofilm, and there's a little picture here. It results of wound bacteria growing in clumps. It gets embedded in and real thick, and it's kind of this slimy barrier of sugars and proteins, and it can contribute to antibiotic resistant infections and decrease the immune response by the patient. So, and again, there's a little picture here to try to show you what that biofilm is. As we continue on with factors that will affect wound healing, some of these we've already kind of mentioned. Age, again, children and healthy adults heal more rapidly than our older adults because older adults are more likely to have chronic illness. We talked about how their skin is more fragile and those type of, they may have some mobility issues. So again, age is a factor that affects our wound healing. Circulation and oxygenation. We have to have adequate blood flow to deliver nutrients and oxygen to that wound to get it to heal. And so certain chronic diseases can impair that circulation and oxygenation and then obviously play a factor in our wound healing. Our nutritional status, wounds heal. We need a high protein diet when we're talking about wounds to have that tissue repair and rebuild. We need our patients to have calorie intake. They need vitamins A and C, and zinc are important to that healing, and fluids is necessary. So if we have a malnourished, dehydrated patient, we're going to see signs that affect their wound healing. The cause of the wound is important because it directly impacts on assessment and treatment. Medication and health status. So there's certain meds that can interfere with that wound healing or delay in that. Or immunosuppression. If a patient is immunosuppressed, that is going to delay some wound healing. And just adherence to a treatment plan. If they don't adhere to properly changing their dressing, cleaning the wound, and they don't follow those, whatever directions are sent home with them, they may have a negative impact on their wound healing. So we've went through the stages of our wound healing, all the factors that affect it. Excuse me, sorry. And now we're on to what are our wound complications. So we are having complications from our wounds. This can increase risk for generalized illness and death. It usually lengthens the patient's need for healthcare interventions, and it can add to healthcare costs. And four that we're going to talk about through this PowerPoint are infection, hemorrhage, dehiscence and evisceration, and fistula formation. So infections are a huge concern with any wound, especially those in our elderly patients and those that are immune compromised, but it can happen with any wound. Usually symptoms can occur or will occur 2 to 7 days after the injury or surgery, and the things we want to watch for with a wound is that purulent drainage. They may have an increase in drainage. They may have pain there. You may see a lot of redness. This picture of a wound that we've placed in this PowerPoint, you can see how much redness is around that site. That would make it probably conclude that there might be some infection going on. You might see some swelling around that wound. The wound itself, like if we felt the skin right here in this picture, may feel warm to touch as we feel around that wound. You may also see an increase in body temperature. And if we were to draw some blood levels, you may see an increase in the white blood cell count. This can lead, infections and wounds can lead to even further complications like bone infections and sepsis. So, infection is a huge complication that we see from wounds. Hemorrhage is our second complication. And again, this is when it can occur, if a patient has surgery and there's something wrong with the suture or some dislodged clot at the wound site, we may see that the patient begins to have a huge amount of bleeding from that wound. So the big thing is if you have a new surgical patient, you want to check that dressing very frequently during the first 48 hours. And then no less than every 8 hours afterwards. I will say with surgical patients, usually the physician likes to be the first one to do the dressing change. So again, when you're being aware of that, when we're looking at that wound, we're going to check that dressing. If we start to see a lot of blood soaking through, we may want to reinforce that. But we want to keep an eye on that because if it seems like an excessive amount, and we keep reinforcing that dressing with a dressing on top of it, and we continue to have a lot of blood, we're probably going to need to call the physician. We may see that we need fluid replacement is necessary if they're losing a lot of blood, and we may also have to take that patient back to have some type of surgical intervention. So it is very important to watch our dressings, to check our wounds, and then we also need to be checking the sites as well because you could have an internal hemorrhage. And if a patient has an internal hemorrhage, we're going to probably see some type of hematoma formation. So, our third complication we're going to talk about, there's two of them here. Dehiscence. The definition is a partial or total separation of wound layer as a result of excessive stress on the wound that is not healed. Increase in fluid flow from wound between postpartum days 4 and 5 may be a sign of dehiscence. So we want to watch this. This top picture shows what this definition is talking about. So we have a surgical wound, it's healing, but with increased stress to that area. So especially this is in the chest, but if you had a patient with an abdominal incision and they're having to use those muscles to get up and down and to bend and to lift, they are in jeopardy of having this happen to their incision. And it can take longer for that area to heal. And is a huge complication that we want to keep an eye on. We want to educate our patients. We want our patients to splint their incision area when they're getting up and moving around. The second picture that you see here is what we call evisceration, and that definition states it's a most serious complication. The wound completely separates, and then you have protrusion of viscera through incisional areas, usually caused by increased flow of serosanguinous fluid about 3 to 11 days post-op. So this is basically, this patient has an organ coming out of their wound. If this would happen, this is emergency treatment. You need to immediately cover the wound with a saline or wet dressing, preferably a sterile towel or dressing soaked in sterile normal saline. We want to immediately call the physician. We do not want to try to reinsert the organs. We just want to cover it. We want to place the patient in supine with the hips and knees bent, and we want to watch for signs of shock. But you do need to immediately cover that wound. Again, sterile towel soaked in sterile normal saline, and call the physician immediately if this would happen. This is a very serious complication. And then lastly, we're going to talk about here fistula formation. And so the definition for this is an abnormal passage from an internal organ to the outside of the body or from an internal organ to another. The presence, increases risk for delayed healing, additionally infection, fluid and electrolyte imbalances, and skin breakdown. So the first one, the picture here, it's trying to show you a bladder fistula. And so there you've got this little tunnel basically going between the two organs internally. The second picture here, you've got a little small, I don't know if you can see it, like a dot there, and that's to show you a fistula that's going from an internal organ all the way to the outside of the body. These are very serious complications because they are very hard to get healed up. They take a lot of time regarding healing. If it's an external one, like the bottom picture, you may see the physician trying to pack it to help it heal. But again, this is just another complication from wounds to be aware of, and that's fistula formation. Hopefully you're still with me on this PowerPoint. We are on slide 35, and we are heading into pressure ulcers. So I've already mentioned this a little bit, but the definition is a wound with a localized area of tissue necrosis or tissue death. Other terminologies you may hear this called by is a decubitus ulcer, a pressure sore, or a bed sore. These are very costly in terms of the patient discomfort, the disfigurement they can cause. It's definitely a decrease in quality of life for a patient who has one of these, and the healthcare expenditures or cost to the healthcare system if a patient develops a pressure ulcer. So we want to try to prevent these. We're going to, on the next few slides, talk about factors in pressure ulcer development, and we're also going to talk about some of the risks for a pressure ulcer development. So when we think about factors that develop a pressure ulcer, it's again that external pressure. As I said, you have a bedridden patient, it usually occurs over their bony prominences, such as their sacrum, followed by their trochanter and heel. They can form very quickly. They can form in as little as 1 to 2 hours if a patient has not been moved or has not been repositioned. So that's why when you have a patient with decreased mobility or they are bedridden, it is so important that we are turning our patients, that we are repositioning them, because again, these can form very quickly. It can also happen with friction and shear. So the definition for friction is it occurs when two surfaces rub against each other. So this can occur when a patient lies on a wrinkled sheet, for example. Skin over elbows and heels are often injured when the patient lifts themselves in bed. We can also see this occurring on the back when the patients are pulled or they're slid over when being moved in bed. So we want to be aware of how friction and shear impacts that. And shear, the definition is occurs when a layer of tissue slides over another layer. Can occur when a patient are pulled rather than lifted when being moved up in bed or from a bed to a chair or stretcher. The next couple of slides are our risk for pressure development, and some of these, again, I hit on over and over, but it's just very important to remember these factors that place a patient at risk for a pressure ulcer. And again, immobility is a huge, huge concern. You may have patients who are unconscious or paralyzed, have cognitive impairment or other physical limitations. Surgeries can cause immobility. If a patient is on a sedative, pain medication, anything where the patient is not moving places them at risk for a pressure ulcer. Nutrition and hydration, again, if we have a malnourished patient, the cells are damaged easily. Protein deficiency, electrolyte imbalances, insufficient calories, and dehydration can all interfere with the circulation and the cell nourishment, and it increases their risk for that pressure development or pressure ulcer development. As we continue on, with that risk factor for pressure ulcer, moisture. So when we think about moisture, primary sources, perspiration, if the patient's really sweaty, urine and feces and wound drainage. So if you have a patient that's incontinent of urine and feces, it is so important that we are checking them and we are changing them frequently. The more alkaline a pH promotes this premature shedding of skin cells, and it decreases the skin's defenses against bacteria. I've seen multiple patients that are incontinent of urine and feces, and they begin to have this red and sore breakdown of their skin. So, again, it's so important that we are checking our patients and we are changing our patients frequently. And the same with wound drainage. If we are getting a lot of wound drainage out, eventually, if that's laying on the skin for too long, we are going to see some breakdown from that wound drainage. Mental status is a risk factor for pressure ulcer. Any patient that's confused or in a comatose state can diminish their self-care activities and increase their likelihood of skin breakdown. And again, we go back to that age and that elderly population, that the aging skin is more susceptible to injury, so they're more prone to have this breakdown. So just knowing that as a factor, we really need to keep an eye on our elderly population and their skin. And before we begin to talk about pressure ulcer staging, this slide was just put in here to kind of give you common areas for pressure ulcer. And so just to be aware of that, if you have the patient lying in bed, um, on their side, their back, or even their front, they are prone for these areas. And then also the patient in the wheelchair, if they're sitting in a wheelchair all day and we have not repositioned them, they are going to have possibly some type of skin breakdown or pressure ulcer. So as I said when we were talking about the phases of wound healing, I said we would get into the staging of pressure ulcers. So the first indication of a possible pressure ulcer is this blanching of skin. So it becomes pale and white over the area under pressure. Pressure relieved and reactive hyperemia, or an area red and feels warm but blanches when slightly pressure applied, occurs. If that pressure continues to that area, we'll begin to see some death of that skin area, and circulation will become further impaired. And so it's very important as an intervention, as a student, as a nurse, is early recognition of a pressure ulcer and its development. And so the next few slides, we're going to talk about how we classify these. And there's 6 stages we can classify as. Suspected deep tissue injury. We can also classify as a stage 1, a stage 2, a stage 3, a stage 4, and an unstageable. This is just some pictures to kind of, if you're a visual learner, kind of see what happens with each stage. So as you see, stage 1, we start to see that reddened area. Stage 2, we have a little bit of more breakdown into the tissue. Stage 3, stage 4, and so on. And I'm not going to say much more because we're going to talk about each of these stages and look at some other pictures of these. But this is just a diagram or picture for those of you who want to refer back to it after we've went through each slide regarding the stages. So the first stage we're going to talk about here is that suspected deep tissue injury. And this presents itself as a purple or maroon discoloration, but the skin is still intact. It is caused by damage to the underlying tissue. It can present as very painful. The area may be firm or mushy, boggy, warmer or cooler area as compared to adjacent tissue. So as you can see, with these pictures, you see that dark maroon, especially in the middle one there, that dark maroon purplish color. We would stage this as a suspected deep tissue injury, and this is a stage that is considered a pressure ulcer. Stage one is that beginning stage of a possible pressure ulcer. We have intact skin, which is non blanchable. We have redness of the localized area, usually over a bony prominence. The tissue may even be a little swollen. Um, there's some discomfort at the site. Darker skin tones may not have as visible blanching, but color may differ from the surrounding skin. So these pictures, one is of the buttocks. You can see that beginning stage one red area. The other one is of a patient's heels. And so again, we haven't seen that, or the skin is still intact. But if we don't take the proper interventions to stay off of this area, we're going to cause further skin breakdown to this area. So this is our first stage, and this is where we want to really start turning that patient and moving that patient off of that area if we see this on a patient. Stage two pressure ulcers, we start to see that partial thickness skin loss where we're involving the epidermis and the dermis. Um, it can seem superficial and may appear as like an abrasion or a blister or a shallow crater. Edema may persist, and the ulcer may become infected, possibly with pain and drainage. So, the picture here is to give you an example of a stage two. Again, this is, we said that pressure ulcers are very painful. This is a very sore area. We're seeing that top layer becoming involved. And again, we want to really take the interventions if we see this to document this and try to get the patient off of this area. Our third stage is where we start to see the full thickness tissue loss with damage or necrosis of the subcutaneous tissue. So it's getting much deeper. The ulcer may extend down to the fascias. The ulcer appears as a deep crater. Slough may be present, but does not obscure how the depth of the tissue loss. We haven't, so this is this stage before the fourth stage. We're not seeing any exposure of muscle or bone yet, but usually there's drainage and infection is very common with these type of wounds. Pressure ulcers that get to this stage or to stage four, they fascinate me because I'm always amazed because it's such an easy intervention to reposition and turn our patients and get them off of these areas when we start to see that redness. And I just feel like areas like this should not get to a stage three or stage four if we're doing the appropriate nursing interventions that need to take place. So again, this is not good. Again, you can see how painful this would be, but we are seeing that damage to that subcutaneous tissue. It's beginning to become a full thickness tissue loss, but we are not yet exposing muscle or bone. And now we are to stage four. Stage four is just bad. Again, these stage three and stage four, with this tissue loss, it's going to take a huge amount of time for these areas to fully heal. But we see full thickness tissue loss. We see with destruction. We see tissue death or necrosis. There is usually damage to the muscle or bone, or we can see that or supporting structures. We could also begin to maybe see some tunneling. We may see what's called eschar, which is this black scab-like material. You can see this yellow kind of slough to this area, an extension of the wound edges underneath. So again, these are very deep wounds. These are very painful, and just we don't want to see any patient have this extensive of skin breakdown and damage. Stage four is really bad. That's when, you're talking about it getting involved with the muscles and bones to these areas. And our last pressure ulcer staging we're going to talk about is the unstageable. So basically, when we have something like this, and there's pictures here to visually show you, we have this ulcer, and it's covered by this slough or black eschar material, and that's just dead tissue, and we can't see underneath it to see how deep it goes. And so that's why it's an unstageable pressure ulcer. As you are taking notes, as you're reviewing this topic, please make sure that you understand the differences in the staging, and really look and take notes and study pressure ulcer staging. So we are a little later in this slide going to talk about interventions and things for wounds. But before we can do that, we have to talk about assessing our wounds. So when we have a patient with a wound, we need to make sure we are looking at it or inspecting it. We want to palpate around it. We want to decide if that area feels warm to touch. We want to assess it for any drainage, odor, and the patient's pain level with that. And we'll want to try to determine the status of the wound. Again, we've talked about how to stage a pressure ulcer. We've talked about the wound healing phases. So we want to determine, where is that wound as far as its healing? Where is that wound as far as the stage that it's in? We want to identify any barriers to the healing process. If we have a patient that has a pressure ulcer to its coccyx or buttocks area, and they are incontinent of urine and feces, we've got a huge barrier to that healing process. We also want to identify signs of complications. And again, early recognition, sorry, I can't talk today. It's a long PowerPoint. And interventions are key to minimizing the complications and healing time for our wounds. So just going a little bit further, and you will do some of this, I believe, in Skills Lab, but you want to, when you're doing a wound assessment, what location is it at? Because you're going to have to, in your documentation, describe the location in relation to its nearest landmark, or where is that incision at? Is it in the right lower quadrant of the abdomen? We're going to want to measure it. And we're going to also want to note the length, the width, and the depth of that wound. Are the edges well approximated? So as you can see in this first picture, we have this perfect surgical wound that's been sutured. Those are well approximated edges. If I look up at the top picture where the person is measuring that wound, I can tell those edges are not well approximated. So we want to we want to assess the wound edges. Do we want to assess for signs and symptoms of infection? Again, do they have redness, warmth to that area? Is there foul, purulent drainage coming from there? Those would all be signs and symptoms of infection. What does the wound bed look like? Is it pink? Are we seeing granulation tissue? Is there beefy red or the sloughing yellow material in the wound? Or are we seeing that black necrotic tissue? So again, what is the appearance of the wound? These are the things we want to assess for. When we are assessing the drainage of a wound, we want to use the correct terminology to describe that drainage. That is why this slide is here. If we see what we call serous drainage, this is clear, contains a little serum of blood that is watery clear and could be occasionally slightly yellow. We've put two sets of pictures here. And when looking at these, it's the top left on each of these slides here is what we are considering serous wound drainage. The next term that we may use when we're describing wound drainage is serosanguinous. This is a light pink drainage. It contains some serum and red blood cells. In your bottom picture here where it says know your exudate, it is the bottom left picture. That is what we consider light pink, and we would describe that as serosanguinous in our documentation for that drainage. Sanguinous is a bright red color, contains serum and red blood cells. In the know your exudate picture, it is the top right one. And then we have what we call purulent drainage. This can be yellow, green, brown, tan. It's often thick. It often has a foul odor to it, and it contains white blood cells, tissue debris, and bacteria in it. So both pictures have purulent drainage. The top picture, it's the top right one. It's kind of yellowish brown color. In the Know Your Exudate picture on here, it is the bottom right one. It's kind of this greenish color. Um, we want to make sure we are using this correct terminology, especially when we're describing purulent drainage. We never want to use the term pus. We don't use that in our vocabulary as nurses because if you're trying to describe a wound that is pussy, if you spell that out and you read it, it says something else. I'm not going to say it here on the PowerPoint, but you can write that word out and you will see what that spells. So again, I should not hear that terminology coming from you. From now on, you will refer to yellow, green, brown, tannish drainage as purulent. Make sure you know the difference between serous, serosanguinous, sanguinous, and purulent drainage and look over these. Some of these slides are repeat of what we've already talked about. When we think about psychological effects of wounds and pressure ulcers, they are very painful. A lot of pain involved with those. A lot of anxiety and fear by patients. They know it's going to hurt when you touch it. They're fearful of how it's going to feel or how it's healing. Another psychological effect is it affects their activities of their daily living. And then they also may see changes in how they feel about themselves or their body image. When we are assessing a wound, we always want to make sure we're getting a pain assessment. So this gives you here on this slide a 0 to 10 scale. We are asking our patients before their dressing changes. We're assessing what is their pain level. And then we always want to assess their pain level afterward. Pain seems to increase when you have more purulent drainage or delayed healing or infection. We also want to, if we know we're going to do a dressing change at a certain time and we know the patient's having a lot of pain from this area, we want to try to medicate them before we perform that dressing change. So it's so important that we are assessing a patient's pain, especially in regards to wounds. This slide is in here, evaluation of existing pressure ulcers. If a patient comes into a facility, they already have a pressure ulcer, you can use a color classification system of red, yellow, and black to kind of evaluate that existing pressure ulcer. Red means we need to protect it. So the wounds are in the proliferative stage and reflect a color of normal granulation tissue. We need to protect that area. We need to keep the patient off of that area. You know, if they have that red area to their heel, we're going to elevate their heel so it's not touching anything. Yellow indicates a presence of exudates or slough, and you may need to clean or cleanse that area. And B stands for black or debride. And this indicates a presence of that dead tissue that needs to be removed before the wound can properly heal. And there is a picture of this R, Y, and B on a wound, and it is in your book on page 1063. It's in box 32-4, and it goes into a little bit more depth about this evaluation of an existing pressure ulcer and using this system. We are now in slide 54 of 77. So we are almost done. Hopefully you are still with me taking notes. We're moving on to types of drains, which is in this skin chapter. And so this is just a list of common types of drains, and we're going to kind of show you each one. But just be aware of the names: Penrose, Jackson Pratt, Hemovac. Those are all very common used drains, and there is a book about common types of drains. It is on page 1064, and it is table 32-4 if you want to look at those a little bit more closely. So as we continue on from that past slide of common types of slides, the first one I'm going to talk about is an open drainage type of drain, and that's called the Penrose. And there's no collection device attached to this. This drains into an absorbent dressing. It uses passive drainage, which means from an area of greater pressure to lesser pressure. And you'll see the picture here. And if you notice, there is a safety pin in this tubing or this Penrose drain. And that safety pin is placed on the outer portion to keep the drain from slipping into the wound, because this drain is not has not been surgically I'm sorry, not surgically, but is not have an incision holding it intact. So it can easily slide in and out of the body. So to prevent that, we put a safety pin in it. And so this is just to give you a visualization of what a Penrose drain is if you would see one in practice. And it is an open drainage system. The next few slides are over these very common closed drain systems regarding wound drains, and we call this the Jackson-Pratt. It's this first two pictures here. It's like a little bulb type of drain. You will also hear this referred to as a JP drain. So if you hear that term JP drain, they're referring to a Jackson-Pratt drain. Hemovacs are the next, the last two pictures on this slide. Again, just another type of closed drainage system. They're connected to suctions devices, and they maintain kind of this continuous low suction. They are sutured in place, and these are good for allowing for accurate measuring of drainage. So if you have a post-op patient that has one of these, you want to be assessing this pretty frequently and emptying this if it is filling quickly. And the next few slides are some pictures of these drains, and they are just for your knowledge to be able to visually see this. So again, as I said, more pictures here visually. The first picture to your top left, again, we're showing the JP or Jackson-Pratt drain, that bulb, and then the Hemovac. The pictures, the two on the bottom, show these JP drains hooked to patients. And we're going to talk, I think, in the next few slides about how to empty that. So as this drainage fills that bulb, that bulb is going to expand. And then when we empty it, we want to press that bulb flat before we put the lid on it, because that is how we get the low suction to help it drain. The same with the Hemovac. As drainage goes in, that is going to expand. And then after we empty it, we want to push it down like an accordion and put the cap on that so that it will continue to drain. And this is that top right picture is just showing a individual emptying a Hemovac drain. This is just a continuation of what I was saying about the JP drain, the bulb. The nurse is emptying it. You can see a picture on the top row on the right of the nurse emptying that. And as we, I think you can see here on the bottom right, we want to push that kind of close that bulb or flat before we put that lid on it. So that's what it should look like after we've emptied it and we want it to continue to drain more. Again, more pictures of that Hemovac. As you can see, we've emptied it. We want to compress the unit to form kind of a vacuum. So it will, and then we want to replace the plug on it. You can see in this last picture the nurse doing that. And then that will expand as the patient has drainage out of the wound area that this is placed in. So I didn't see this talked about in your textbook, but I always like to put this slide in this presentation. And this is what we call a wound vac. And so you will see this on patients If we're talking about patients that have that stage 4 pressure ulcer, it's super deep, it's down to the bone, you may see them apply a wound vac. It promotes healing through continuous negative pressure to that area. It begins to remove all this excess fluid from the wound area, and it promotes the cell proliferation. And so the first picture is a wound vac applied to a wound on a patient. And the second picture here is just what the device looks like. And this is what's providing that continuous suction to this area. So I just wanted you, I don't know that your textbook talks about these, but we are seeing more and more of these in the acute clinical setting for patients that have these really deep wounds that are not healing, that they've had for a very, very long time, and they're seeing really good results with the healing once they've applied the wound vac to that area. Your textbook goes into introducing sutures and staples. Again, this is fundamentals is kind of an overdue, just introducing you to things. So if a patient has surgery, you will see that they will come back, and there's usually some method to hold that tissue and skin together, and it can be in the form of sutures, which is a surgical thread that they've applied to hold that wound together, or staples, which is the second picture of how they've done that. With sutures, it may be that the thread they've used is dissolvable and you don't have to do anything with it. It may be that these have to be removed after a period of time. And then staples, you can see in the second picture here, we usually do take those out after some time with a staple remover that you see here in the picture. Alrighty, we are almost done with this presentation. Slide 62 of 77. And we've talked about assessments, we've talked about drains here at the end, and we're back to pressure ulcers. And this, what we're going to talk about is preventing them. And we're kind of back on that topic again. I know we've talked about pressure ulcers and then we went to some other things, but we're back to it. So preventing pressure ulcers. And so this is just a good little visualization. We always want to place pillows strategically between bony surfaces to try to prevent that pressure to those areas. Maintaining head of the bed at 30 degrees to relieve some pressures to that sacrum or buttocks and heel area. Keep our clients from sliding down in bed because of that friction and shear. We want to lift rather than pull our clients up in bed, so it's important to have like a lifting sheet under our patient. It's important to get some help with our heavier patients that can't help us move up in bed to prevent that friction or shear. We're going to raise our clients' heels off the bed because we can easily place a pillow under their lower legs that will assist with keeping their heels off the bed and getting those sores. We're going to ambulate as soon as possible with our patients. We're going to get them moving. We're going to implement active and passive exercises. We don't want to massage those bony prominences, especially if we see reddened areas to it. We do not want to do that. And we want to be providing adequate hydration and the meat, protein, and caloric needs for our patients. So these are all things we are going to do with our patients to stop that pressure ulcer forming. Again, just a quick little reminder, we've talked about some of this. This is if we're preventing pressure ulcers, and a little visualization of what we're assessing for. Surface, we're going to make sure the patients have the right support. Skin inspection, we're going to assess our patients frequently, and we're going to be looking at their skin. We're going to keep our patients moving. We're going to be watching for incontinence, which I talked about is so important because of that moisture that can cause problems. We want to keep our patients clean and dry. If we know they're an incontinent patient, we want to check on them hourly because it does not take long for a pressure ulcer to form, and that nutrition and hydration. So this is just another By the end of this, you should have this all very well memorized. We want to, if we're trying to prevent a pressure ulcer, another thing to look at is that maintaining that nutritional status. There are certain laboratory criteria that can indicate a patient is nutritionally at risk of a pressure ulcer, and we've kind of listed those here for you um, to kind of begin to make a connection with those values and nutritional status for a patient. We have the pressure ulcer assessment tool. You will see this used a lot in the hospital for anybody that could possibly be at risk for a pressure ulcer. And this risk assessment, the one that I've seen the most frequently is called the Braden scale. It consists of 5 components. We're looking at their mental status, if they're continent or incontinent, their mobility, their activity, and their nutrition. And we can use this to predict their risk. So, depending on where they land on the scale, um, the higher the number, the lower the risk. If they have a low number, as you can see, they're at high risk. So it's kind of the backwards way of thinking about it. But just being aware that this is a tool that you will see frequently used on patients to assess if they're at risk for a pressure ulcer. This is a summary just to talk about wound care and wound management. When we think about interventions, we want to remember that our goal is to promote tissue repair and regeneration. Treatments may be having the wound open to air, or it may be beneficial to close the wound for care. Again, a summary. Open to air, the wound heals more slowly as a scab. If the scab is removed accidentally before healing is complete, we have that re-injury that occurs, new cells are exposed, and we're more prone to environmental factors and potential injury. A closed wound, we're using dressings to keep the wound moist, and that is best for wound healing. We are promoting wound healing with that. We want to keep the wound surface moist. And so again, this is just a summary. We've said a lot of this throughout the PowerPoint when we've talked about classification of wounds, when we talked about the stages of wound healing. And again, this is just a reminder of wound care management and the overall goal for that. Further, for wound care management, when we are having to change a dressing, I just wanted to hit on this. There's no standard for frequency as far as changing that. It all depends on the type of drainage that wound is having, the practitioner or the doctor's preference on how often that wound gets dressing gets changed, the nature of the wound, and the wound care product. However, as I stated earlier in one of the slides, if you have a surgical patient, that first dressing is usually changed by the physician or an advanced practice professional, and it's usually done within the first 24 to 48 hours of surgery. But we do want to keep an eye on that dressing. How much drainage is coming through? Do we need to reinforce that drainage? We're watching for signs of hemorrhage with that. And so just being aware of that. Again, with wound care and wound management, the purpose for addressing, we're trying to prevent, eliminate, or control infection. We're trying to absorb a drainage when we have a wound dressing on, because we know that drainage, if it's on the skin, can cause more skin breakdown. We're also trying to maintain a moist wound environment so that the healing can be promoted. And we're trying to protect that area from further injury as well. I've stated this multiple times, how important hydration is, and protein and calorie needs. Some things to keep in mind if you're caring for a patient: what are our good sources of protein? What do we want to encourage our patient to eat? And that is meat, fish, and poultry, eggs, dairy products, beans, nuts, and whole grains. So we really want to have a very nutritious, high protein diet for anybody who has a wound. And again, we've said this multiple times, with any lack of protein, there is a greater risk for that delay in wound healing infection. So it's very important that we have that in mind and we keep hydration and protein and calorie needs met for the patient. Next few slides are about changing of the dressing. You guys will practice changing a dressing in your skills lab. Um, but remember how we talked about previously in PowerPoints that we really want to assess a patient's pain. Before we do a dressing change, we want to make sure we're administering that pain medication at least 30 to 45 minutes before the dressing change. We want to try to change that dressing in between meals. We're going to use appropriate aseptic technique. So if you have a surgical wound that has dehisced, you may want to be using a more sterile dressing change to that area because it will be more prone for infection. Pressure ulcers, when we do dressing changes to that, they tend to be non-sterile, and we're just using clean technique with those dressing changes. Before doing a wound dressing change, you always want to check your physician's order for the order, and you're looking for how often it's supposed to be done, what type of dressing change needs to be done, what supplies you're supposed to be using. You want to always make sure you have all your needed materials gathered at the bedside before you begin that procedure. You're always going to explain to the client what you're about to do, answer any questions that patient may have. We want to remember to provide for privacy. When we remove that old dressing, we're going to be very careful, especially with removing any tape that may be applied to that dressing, because remember we talked about how skin can be fragile, especially in our older population. We're going to pull up that small portion of the tape and kind of push it away from the skin very slowly. We're going to use possibly adhesive removers to get rid of or to take that tape off easier, especially for those that have real frail skin. We're going to know when we take that dressing off that amount of drainage we have, the color, what type, is it sanguinous, serosanguinous, serous, and if it has any odor. We're going to kind of try to remove it so that the patient doesn't necessarily see that drainage. We're going to discard that dressing. We are going to wear gloves while we're doing this. And then once we've got that dressing removed, we can take those gloves off. We're going to perform hand hygiene and then perform a clean dressing or a sterile dressing change. This slide is to discuss wound care and the dressing change and how we're going to cleanse that area. Most of the time when we think about cleansing agents, again, we're going to want to check that physician order. What does he want the wound cleaned with? The most common cleansing agent that we will normally use is normal saline. Occasionally the physician will order some type of commercial wound cleanser as occasionally. But most of the time, if they don't have a specific wound cleanser listed in their orders, we're just going to use normal saline. We're going to moisten a sterile gauze pad with our cleanser. And this goes back to talking about well-approximated edges versus unapproximated edges. So if we have that perfect surgical incision, we are going to want to cleanse the wound from top to bottom. We're going to start at the middle of the wound, as you can see here in the picture, and we're going to cleanse. And then we're going to clean the edges to the left, clean edges to the right, then the left, and we're going to work our way out. Each time we make a swipe, we're going to use a clean gauze with the cleanser on it. So you're going to need several gauze pads when you're cleaning a wound. So to make sure you have the appropriate amount of dressing supplies at the bedside, and being aware that you are going to probably need at least 5 to 7 gauze pads, because you want to use a clean one with each swipe. Unapproximated, you're going to start in the middle of the wound and you're going to cleanse out in a circular pattern. You will use a new gauze for each circle, so you can see the picture here. So again, when you go into a patient's room, you want to assess that wound. What does it look like? Do we have approximated or unapproximated edges. We want to check our physician's order. What kind of dressing change have they ordered? Is there any special wound cleanser they have ordered? And that way we can take the correct supplies into the room and we know the correct method we want to cleanse that wound in. Once we've cleansed that wound, we're going to apply a new dressing. And sometimes it's important that we apply a skin barrier as needed where a dressing has adhesive or tape. So this is a barrier that we would put down, spray down before we would place that tape. And it's just again to protect that skin. We're going to place that dressing in the center of the wound, and it should extend about 1 inch beyond the wound. If packing is needed, we're going to apply the packing to the wound surface and ensure that edges are covered. When we're securing our dressing, depending on what we're doing here, we're going to do tape to kind of create a window by covering all the sides of that dressing with the tape. And this, again, just lists some different types of securing a wound. I've seen patients have a dressing, gauze or ABD pad placed over their wound, and then we've secured it with an abdominal binder. So that may be a method. And so again, I don't want to, I know you've been listening to this PowerPoint forever. You think it's never going to get over. We're on slide 72 of 77. But again, these are just some methods of securing a wound dressing just to be aware of. We talked about fistulas as a complication of wounds. And many times, as I stated, if you have a fistula, sometimes the physician will want that area packed. And it's not necessarily just fistulas. If they have a deep wound or a pressure ulcer, the physician may also order for that to be packed. There'll be specific orders. The material that you're packing, you want to moisten that material as ordered. You're going to place in the tunnels and the undermined areas first. So as you can see in this picture, this person has a Q-tip and they have the packing material and they're lightly using that Q-tip to try to get that that gauze placed in the areas and undermined areas first. We're going to pack it loosely. Once we have that wound packed, we're going to cover that entire wound bed with a dressing. We use one piece of packing normally. We want to try to keep the packing off of the intact skin because if we have it laying on that skin, we are possibly exposing microorganisms from the skin onto that gauze, and then we're putting that into the wound. So that's why you can see in this picture that the other hand that the nurse is using is holding that packing up so that it is not laying on that patient's skin. And then we want to secure that dressing as ordered. Again, when we are thinking about our wound dressings and what we're going to use, we want to maintain that moist environment for that wound. We want it to be absorbent, provide some thermal insulation, act as a bacterial barrier, reduce or eliminate pain at the wound site, and allow for a pain-free removal. So those are all things to keep in mind when we're trying to pick the ideal dressing for a wound. With that goal in mind, again, this is just with the goal in mind of what we want a dressing to do for the wound. These are just some pictures of different types of dressings, just to give you some examples. We are our last two slides here. So slide 76, collecting a wound culture. It's very important that we want to clean the wound first. We want to get a culture test or a swab. You can see in the second picture what that would look like. We want to keep that swab and inside of the culture tube sterile. When we remove the swab, we don't want it to touch anything because again, we're trying to keep that sterile. We want to rotate the swab over the wound surface several times. We do not want that swab to touch intact skin at the wound edges. We want to keep it inside the wound. because that could result in inaccurate results. We're going to use one swab per site to prevent cross-contamination. So if your patient has multiple wounds and they want wound cultures, we're going to need multiple culture tubes to do that. So we only want to use one swab or one culture tube per wound site when we are trying to obtain a wound culture. And this is our last slide for this chapter. I'm sure you're as excited as I am. And it talks about removing sutures or staples. So staples, we want to get a sterile staple remover. They will be kits on the unit. And a closed staple remover is used to kind of crimp the staple and lift up on it upward. After staples are removed, you may want to apply steri-strips after removal. Again, you can check your physician orders to see if that's wanted. Sutures removed when the wound develops enough strength to keep the edges together. Time can vary, but sutures are typically removed within 6 to 8 days to prevent suture marks. We use a sterile suture removal kit for that. We want to cut below each knot close to the skin and pull then the sutures up through using a tweezer that comes in that kit. That concludes our chapter. This is a very long chapter. Hopefully you've taken some breaks as you've been listening to it. Things, as we kind of summarize, things you need to be looking over, go back over with your notes. What is the function of our skin? So in the very beginning of this chapter, we talked about the functions of our skin. We went into how do we classify our wounds. We've talked about the wound healing phases. I would definitely look at those. We've also addressed the staging of pressure ulcers. How do we want to prevent pressure ulcers? And just the care of wounds in general themselves. What puts a patient at risk for pressure ulcers? So that's just a summary. Lots of content in this chapter. Make sure you go over your notes, you do the preppies for this chapter so that you can be prepared for the test. Have a great day. Thanks for taking your time to listen to this very long PowerPoint.